important, like it is too important, whether at the level of step one or whether at the level of step two. What I need you to understand, what I need you to understand is this. If they give you any cardio question, whether it is from your MBME, from your UWorld or anywhere, if they mistakenly give you chest examination finding in that question, and they now added a murmur location to that question, forget it. You should not fail that question for any reason, because those questions are stereotype. It is neither here, it is either this or nothing else. So that is exactly where we're going to be dwelling on in today's class. Let me just give you an example. They gave you a question where they tell you, oh, a 64-year-old man comes to the hospital with complaint of this. Now, on examination, a holosystolic murmur was heard at the mitral apex. That has already given you the answer to that question. Just that single line has given you the diagnosis. Just that there's a holosystolic murmur, grade 2/6, heard at the cardiac apex. You already know what they are talking about. That is all you need to answer that question. So this is where we're going to be sorting that particular concept. Now, I like using the whiteboard a whole lot and using less of the literature. The literature is like a guide. Now, what I want you to understand is that there are 5 murmur areas in your body, and you definitely have to be conversant with those murmur areas. If they tell you to do cardiac examination and do chest auscultation, you're not just putting the stethoscope blindly on the patient's chest. You're rather targeting the murmur areas because you want to hear if the patient has any abnormalities in those flow areas. So the 5 areas you definitely target is the aortic area, the pulmonic area, the left sternal border, left lower sternal border, and the mitral area. Let's look at those areas completely. So let's assume this is a chest wall. Let's assume in between here is the sternum. Now, let's assume this is the first rib. This is the second rib. This is the third rib. This is the fourth rib. And this is the fifth rib. Let's also reproduce the same thing on this side. Like the third. And this is the fourth. And this is the fifth. On both sides. Now, look at the valvular areas, and you need to know this and know it well. Now, 4 of the valvular areas are on the 4 of the valvular areas are definitely divided by this midline chest bone. That is the sternum. So 4 of them are directly aligned to the sternum, but 1 of them will be on the right, 3 of them will be on the left. The heart is on the left, so majority will be on the left. Then 1 of them will be away from the sternum. So there are 5 valvular areas. Four of those valvular areas are directly aligned on the sternum. It is only one that is away from the sternum. Now look at where they are aligned to. The first one is this red one. If this is the first rib, this place will be the first intercostal space, because an intercostal space is the space between the ribs. So the first intercostal space will be between the first and second rib. The second intercostal space will be between the second and the third rib. Now, this is the first place where you have your first valvular area or murmur area. This is the right, this is the left. So when you talk about your second intercostal space to the right of the sternum, that is where you have your aortic area. So this is the aortic valve area. Now, what murmur would you hear here? You will hear the murmur of aortic stenosis. This is the most important murmur. When you come to step 2, I can now tell you, you can hear physiologic murmur there, which is a flow murmur. But at the level of step 1, just know that what you hear here is the aortic stenosis murmur at the level of the second intercostal space to the right side of the sternum. Now, when you look at that same intercostal space on the opposite side, which is what we have here, this is the second intercostal space to the left of the sternum. This one now is what will give you your pulmonic area. There are two important murmurs you will see in the pulmonic area. That is what? The murmur of pulmonary stenosis and the murmur of atrial septal defect. These two murmurs are on the pulmonic area, which is the second intercostal space, the left side of your sternum. Now, let us move one step further. Now, if you look at it, this is called the left upper sternal border. That is another name you call this pulmonic area, left upper sternal border. So there are three names they can use there. They can tell you, oh, the murmur was heard at the left upper sternal border. The murmur was heard at the pulmonic area, or the murmur was heard at the second intercostal space, left side of the sternum. Three of them are talking about one thing. Now, if this black area, which is at the second intercostal space to the left, is the left upper sternal border, there have to be a lower sternal border. So the lower sternal border is definitely at the fourth intercostal space to the left side of the sternum. If this is second intercostal space, this one will be third, this one will be fourth. This green here is now the fourth intercostal space, left side of the sternum. This is where you have your tricuspid valve area. These are where you hear the tricuspid kind of murmur. So what you hear here, this is the tricuspid area. So all your tricuspid murmur and your VSD, this is where you hear them. So I will abbreviate tricuspid murmur as TM. This could be tricuspid regurgitation or tricuspid stenosis. You hear them at the level of the tricuspid valve area. The next one is then your ventricular septal defect murmur. So the three murmurs you hear there are murmurs of tricuspid regurgitation, murmurs of tricuspid stenosis, and murmur of ventricular septal defect. You hear that one at the left lower sternal border, or they can call it the tricuspid area, or they can definitely tell you is at the fourth intercostal space to the left side of the sternum. Is the same thing. Now, if this one is left upper sternal border and this one is left lower sternal border, this third intercostal space between them is supposed to be middle left sternal border. If the one above it is upper, the one below it is lower. Common sense will tell us now the one in the middle will definitely be middle left sternal border. But this is the confusing thing. They remove the name middle from it completely. So the murmur that you hear at this point that is supposed to be the middle left sternal border, just remove the middle and call it the left sternal border. Just call it the left sternal border. So take away the middle from it. So when they tell you the left sternal border is definitely at the intercostal, at the third intercostal space, left side of the sternum. Now you hear some very important murmur here. The most important one is the murmur of hypertrophic cardiomyopathy. You can hear murmur of aortic regurgitation here. You can also hear murmur of pulmonary regurgitation. We have settled the 4 areas. Now look at these 4 areas. They align themselves directly on the sternum. 1 on the right, which is the aortic stenosis. 3 on the left. Second, third, and fourth. Second is left upper sternum. Fourth is left lower sternum. Then the third is the left sternal border. The left upper sternal border is the pulmonic area. The left lower sternal border is the tricuspid area. In the middle is Hokum, most important murmur head there. Then the last one that is outside of the sternum is what we call the cardiac apex. The cardiac apex is somewhere here. It's in the mid clavicular line. That is where the apex of your heart is. Now, the cardiac apex is where we have the mitral area. This is the mitral area. This is where we have the murmurs of the mitral valve. For example, this is where we have the mitral regurgitation murmur. This is where we'll hear it. This is where we hear the mitral stenosis. This is where we also hear the murmur of the mitral valve prolapse. Now, when we started this particular concept today, I made mention of something. I gave a theoretical question. In that question, I said they brought in a 65-year-old man that has a lot of symptoms. Now, they did a cardiac examination and they told you the patient has a grade 2/6 holosystolic murmur at the cardiac apex. Just getting that particular thing from that question, this patient problem, just knowing the location of that murmur, that they said this murmur is at the cardiac apex, I have narrowed the patient diagnosis to only 3. That patient diagnosis, I have narrowed it. What was the murmur location you told me? You said is at the cardiac apex. Automatically, there's nothing you will tell me again. That murmur can only be mitral regurg, it can only be mitral stenosis, or it can only be mitral valve prolapse, one of these 3. It cannot be any other thing. So every other thing that is not among these 3 in the option, I will strike it out in confidence. This is the first thing to learn when you want to approach murmurs. Now, if they tell me, oh, on examination, the patient had a grade 3/6 systolic murmur, best head at the left sternal border. If you tell me that at the left sternal border, I have already biased my answer choice to 3 things because there are only 3 murmurs that can be heard at the left sternal border. This CV before me can be hypertrophic cardiomyopathy. This CV before me can be aortic regurg, or it can be pulmonic regurg. I have narrowed it to those 3 answer choices, and it must be one of them. If you tell me, oh, the murmur was heard at the right upper sternal border, I know that what you're talking about is aortic stenosis. I don't need to stress my head. If you say you heard it at the left upper sternal border, I'm bringing in pulmonary stenosis as well as ASD. This is the first thing you will need to learn to be able to pick out those questions. And trust me, cardiology question, they love that a whole lot. This pathway is about being smart in the right way. If you look at cardio questions, most of the times, they will have to give you the chest findings. You cannot be reporting to your attending. If you're a resident, you're reporting to, or you're a fellow, you're doing fellowship, you're reporting to your cardiology fellow, and you're not putting You're not putting the chest finding. You must put the chest finding. That is the language of cardiology. Is there murmur? Yes, there is murmur. Where did you hear this murmur? How is the characteristics of this murmur? He's asking you for location, because once you just tell him location, he narrows it down to specific disease conditions. That is how they also want you to be thinking. You need to think like them. Now, if this is settled, this is the first thing. Let us go and do the maneuvers. The maneuvers is the second concept you need. So we start with the valvular maneuvers. So the first thing you need to know the location. When you have known the location, know the maneuvers. If you know the locations and the maneuvers, forget it. You have settled that concept completely. Now, there are certain maneuvers you need to know that will either increase or reduce a murmur. Now, what you need to know is that most murmurs increases when you have more blood in the heart. So when blood increases in the heart, that is preload increases, those murmurs will go up. When blood reduces in the heart, those murmurs will definitely reduce. It's just like you see a moving sea that creates turbulent noise. During the rainy season, when that river is overflowing, it will flow with a higher pressure because there is more fluid. That will definitely give you more sound as it's flowing. But during the dry season, when it goes off, you will definitely get a more reduced turbulence when it's flowing, because there's less fluid or there's less water contained in it. Just think about it in that direction. So when there is more fluid, or when there is more blood rather returned to the heart, naturally you're supposed to have more murmurs, because you have more blood flowing through that heart. They will create more turbulence. Less blood reduces the murmur. Now, that is true for all conditions except for two murmurs. This is where the whole concept starts. Every murmur will follow this part I have said, where they increase with increased blood return to the heart and decrease with decreased blood return to the heart, apart from two murmur, which is the murmur of hypertrophic cardiomyopathy and the murmur of mitral valve prolapse. This one goes opposite of the blood flow. If the blood flow to the heart is increased, that is preload, this murmur will go in the opposite direction. They will reduce. On the other hand, if the blood flow to the heart is reduced, this murmur will go in the opposite direction. They will increase. So this is the only two murmur that goes in a different pattern from every other murmur. Now, let's start by looking at Valsalva maneuver. These are the different maneuvers you can do. So you understanding that certain murmurs increases and decreases with increase and decrease preload. So one of the things you can do is, as your patient is on the examination table, you can do some maneuvers that can increase or decrease the preload to see if the murmur increases or decreases. Now, let us look at a maneuver that can increase the preload. So let's start from increase. So this is increase preload. Let's abbreviate it as PR. Okay, PRL. This is preload. So increase preload. Now that will be leg raising, passive leg raising. Squatting can also do this, but squatting will also raise the SVR. So passive leg raising, this is one of the commonest ones. Squatting can also do this too. Now, have you ever wondered when people stand for a long time, especially soldier, they faint? You can see them fall and just faint. Now, why would they have that syncope when they stand for a long time? The reason is this. When you stand for a long time, gravity pulls blood to your leg. The venous return will definitely be reduced. The venous return going back to the heart will definitely reduce. Now, if the person lies down or the person collapse and you raise the person's leg, what you're doing is that you're forcing back that blood back to the heart. Those blood that has been pulled on the leg, you're forcing it back to the heart. Automatically, preload increases. So in passive leg raising, preload goes up. That is the first thing you need to know. Now, when preload goes up, all your heart murmurs will go up. All murmurs. There's only two murmurs that we drop with passive leg raising. That is the murmur of hypertrophic cardiomyopathy and murmur of mitral valve prolapse. These are the only two abnormal murmurs. So if I do passive leg raising for this patient and the murmur reduces in intensity, these are the two I am suspecting. Of course, I will rule out every other murmur. It has to be hypertrophic cardiomyopathy or mitral valve prolapse. Those are the only two that reduces with passive leg raising or increase in preload. Now, what are those things that can reduce your preload? The most common one is the Valsalva maneuver. Can do Valsalva. Just tell the patient to strain. Whenever you strain, that is a Valsalva maneuver. That will definitely cut down the venous return that is coming back to the heart. It is very notorious in doing that because it raises the pressure. Think about it. When you want to cough, your intra-abdominal pressure rises markedly. Just if you attempt to cough, you see the way your abdominal muscles are tense. So pressure goes up. That pressure prevents blood from being returned to the heart. Now, if Valsalva decreases preload, so preload goes down in Valsalva, what we're expecting is that every normal murmur in Valsalva should also go down. So every normal murmur goes down. There is only two murmurs that will go up. That is these two murmur here, hypertrophic cardiomyopathy, and then your mitral valve prolapse. Now, let us take this thing one step further. Let me tie in another clinical vignette now. Remember, when you see a clinical vignette pressing you that gave you a chest finding, the very first question you need to ask yourself is, where is this murmur? The next question that should follow it is, what is the characteristics of this murmur? That will give you the answer to that question. So look at this other question. Now, they told us that a 32-year-old man came to the emergency department. He's been having dyspnea. He has this syncopal feeling. Now, they gave us a lot of other things that were not necessary, but they just put it in the question. Now, after saying all those plenty things, they now gave us a chest examination finding. They said on auscultation, this patient had a grade 2/6 murmur, best head at the left sternal border, and increases with Valsalva maneuver. Now, from the location of that murmur first, the murmur is at the left sternal border. If you remember that diagram we drew, because that murmur is at the left sternal border, that murmur can be one of three things. It could be a murmur of hypertrophic cardiomyopathy, a murmur of aortic regurgitation, and a murmur of pulmonic regurgitation. Those are the only three possibilities. I've already narrowed my mind, my answers to those three things. Every other thing, I have ruled it out of my head. Those are the only things that can occur in that location. Now, they went one step further to tell me that the murmur increases in intensity on Valsalva. That narrows it specifically now to hypertrophic cardiomyopathy, because we settled it that every other murmur will go down with decreased preload, including pulmonary regurgitation and aortic regurgitation. Those ones are under every other murmur. The only true murmur that we go up when preload is reduced is hypertrophic cardiomyopathy and mitral valve prolapse. So this particular question, just that auscultation finding perfectly aligns it to hypertrophic cardiomyopathy. I pick it and I move. I pick it up and I move. You saw the way I did this thing. Now, you see, there's a way this particular process is, there's a way this pathway is. In this pathway, sometimes you make the errors you make, or you struggle a lot because you don't have information, you don't have guide. If you have information and you have guide, you have a grasp of the concept. For example, if I see a cardiology question in my exam, the first thing I go and do is I check, am I having an auscultation finding here? If you give me an auscultation finding, I might not even need to read the entire question. That is because you have gotten an idea of the cardiac concept, like you have it at your fingertip. If you read that question, you will see a lot of things that will confuse your thinking. But every question has the silent points they want you to know. This is just the most important thing. And sometimes you need to train yourself, or you need somebody to guide you to know every single concept. This is the important thing. This is the important thing. That is the way you excel. So if you see a cardiac question from now onward, and by chance they give you an auscultation finding, you are expected to do that cardiac question in less than 40 seconds. Pick your right answer and move on. Use it to buy time for other questions. Because once they give you that auscultation finding, forget it, it is over. It cannot be any other thing. Like this CV now I gave to you, like there's nothing you can tell me that it is not hypertrophic cardiomyopathy. It's not possible. Just that one line made the diagnosis. Now, we have tied in two already, the one that decreases preload and afterload. That is the passive leg raising and the Valsalva. Now, let us look at inspiration. That's another murmur maneuver we can do. Inspiration is definitely when you breathe in. Now, remember what we said when we did the splitting. We said when you breathe in, you have more blood returning to the right part of the heart compared to the left part of the heart. That's what we settled. More blood is coming to the right part compared to the left part. The truth is that the more the blood flow by right, the higher the murmur, except for those two abnormalities. Apart from those two abnormalities, almost every other thing follows the normal flow rate. Now, what it simply means is this. If you now have reduction of blood on the left side and increase blood on the right side, it simply means that the right-sided murmurs will definitely go up at the expense of the left-sided murmur. So during inspiration, this is what happened. There's increase preload to the right. So automatically there'll be increase right-sided murmur. So that's right-sided murmur. It will go up. Now, the final one is definitely that of the hand grip. This is where a lot of people get confused, very, very confused. So that is exactly where I would definitely be talking about it more in depth, because that one is very tricky. You have to have your concept at your fingertip to be able to understand that. But it's actually very easy too to do if you get to think about it. So let us talk about it now. Please, can you mute your mics, everybody? So let me do that on my pad. I was supposed to mute everybody. Um, all right, so I think I have done that. Please, subsequent classes, let's mute our mic. I don't like losing I don't like losing my thought process. If I lose my thought process, sometimes I may omit giving you certain important information I wanted to give to you. So let's just try as much as possible. All right, so if that is understood, then we'll definitely have to move on. So moving on now, we definitely look at the hand grip. The hand grip is very important. Now, this is how I'm going to explain that hand grip for you. Now, let's imagine this is the heart. This is the atrium. This is the ventricle. No, let me redraw this in a better way. That atrium was too big. This is the atrium. This is the ventricles. Now, you will agree with me that the ventricles empties their blood into the aorta. This is the aorta. While the atrium will empty its own blood into the ventricles. Now, see what I want you to understand. When you when you do the hand grip maneuver, what does hand grip do? Hand grip increases the afterload markedly. Afterload goes up very, very much in hand grip maneuver. Now, what I want you to think, remember the concept we have been painting since. When afterload goes up, what will happen? Stroke volume will reduce. That is the blood that needs to move out of the heart into the aorta will go down. Remember, the afterload is a function of the aorta. So if this pressure in this aorta now has gone up markedly, that is the afterload going up from that your hand grip. It simply means that the blood in this heart will not want to come to this point again because it will be difficult to go out via the aorta. You have increased the pressure there excessively. Now let us assume in a normal person, this is how blood flow in only one direction from the ventricle to the aorta. It does not go back because the mitral valve will be closed. But let's assume now this patient has a regurgitation, for example, like a mitral regurgitation. Now, if this patient has a mitral regurgitation, for example, this blood has two pathways it can go. It can come through the aorta, which is what should be in a normal person, or it can go back via this mitral regurg into the atrium. Now, imagine that in this patient with mitral regurg, I do a hand grip for this person. If I do a hand grip, I'm going to increase the pressure in this aorta markedly high. The afterload will go up a lot. Now, if the afterload goes up a lot, this heart, this ventricle wants to pump out his blood, but it will not want to go to the area that has high pressure. Nobody wants to suffer. Because if it goes to that area that has high pressure, it has to do a lot of work to overcome the pressure. So what will it do? It will prefer to come through this regurgitant valve into the atrium because the pressure there is lower. So when you do the hand grip and increase afterload in a patient that have regurgitant murmur, more blood will definitely move through the regurgitant valve, and that murmur will definitely be intensified. On the other hand, less blood will flow through the aorta. So forward murmurs will definitely reduce. Think of this again. The pressure in the aorta is definitely increased. The aorta is the forward movement because blood is supposed to leave the ventricle to the aorta. That is the normal thing. That is a forward movement. Now, if the pressure in the aorta is increased, forward movement will reduce. If forward movement reduces, murmurs in the forward direction will also go down. So something like aortic stenosis, that's a forward murmur because it's occurring at the level of the aorta. In hand grip, it will drop. Now, murmurs that will stay in the regurgitant part, because that is what will now be favored. Since we cannot go forward because of the high pressure, the back has a low pressure. Let us go backward. So the regurgitant murmur will increase. Aortic regurg can go up. Mitral regurg can go up. Another thing is VSD. Why would VSD go up? VSD is a left to right shunt. Now, because the pressure has increased at the level of this aorta, this heart is looking for where to channel the blood to. And if there's a patent VSD here, of course, please go to the right where there is lower pressure. That is why when you look at the hand grip, the VSD, the regurg murmurs like aortic regurg, the mitral regurg will go up. Why the forward murmur, murmur of hypertrophic cardiomyopathy and aortic stenosis will also reduce. This is the second level. Now, the third level is this. Know the characteristics of the murmur, how the murmur sound. I have tied in two things. The first one is the location. The second one is you know the maneuver. The third one you need to know is how does the murmur sound. Now, let's look at that. Your aortic stenosis is a crescendo decrescendo murmur. I'm going to talk about this page, but just pick out how the important murmur sound so that we finish that murmur concept and we move on. Aortic stenosis is crescendo decrescendo murmur. That's it goes up, it comes down. Now, when you look at your mitral or tricuspid regurgitation, those ones are holosystolic murmur. So your mitral or your tricuspid regurg are holosystolic. Your MVP is just crescendo alone. VSD is definitely holosystolic. Aortic regurg is decrescendo. Stenosis is definitely the one that has the opening snap. Now, let's come back again and do this one. See, mitral regurg is holosystolic. Tricuspid regurg, TR, is holosystolic. Now, when you talk about your aortic regurg is decrescendo. Aortic stenosis is crescendo decrescendo. Crescendo decrescendo. Now your MVP is crescendo alone as it is going up. Your mitral stenosis is the one that will have the opening snap. Now look at this question again. Look at this question one more time. Let's go back to that questions we have been saying before now. So we look at this 64-year-old man. He was brought to the hospital for dyspnea, easy fatigability, and a lot of other things. And they kept on telling you things and things and things and things, and you're almost getting confused in the question. And they now give you chest auscultation finding that on auscultation, the patient has a grade 3/6 holosystolic murmur at the apex. There are three murmurs you see at the cardiac apex. The cardiac apex is the mitral valve area. You see the mitral regurgitation, you see the mitral valve prolapse, and the mitral stenosis. Of these three murmurs, the only one that is holosystolic is the mitral regurg. Automatically, I have tied my diagnosis for that particular question as mitral regurgitation, and I'm moving on. Like there's nothing you're doing. I'm moving on. So if you have gotten an understanding or a grasp of your concept, as you just started reading that question and you see that, oh, this question is a question this is a cardiology question. The next thing you ask in split seconds, did they give an auscultation finding? You quickly look for it. If it's there, you look at it, you pick your answer, you move on. By the time you read the entire question and you want to be logical, you will get things, that answer choice you want to take. There are things in the question that can likely tell you it is the correct answer, even though it is wrong. But when you learn how to narrow your mind to the important things in the clinical vignette, you will rarely go wrong. That is how to use this concept. If you're telling me that, oh, you had a murmur at the cardiac apex. So they say on auscultation finding, a murmur was heard at the cardiac apex with steadily increasing intensity, or the murmur intensity kept on increasing steadily. That is a crescendo murmur. That is a mitral valve prolapse. Sometimes they don't need to spoon feed you every time. It is not enough knowing it is a crescendo murmur. Crescendo, what is crescendo murmur? Crescendo murmur is that the murmur intensity keeps going up. That is crescendo. Crescendo decrescendo means it goes up and peaks and start falling. Holosystolic is that the murmur sounds the same way. It doesn't go up, it doesn't come down. Like you hear it in a steady way. So they can give you what you know in different grammatical expression, and you will not know you know it. So it is not enough knowing crescendo murmur. Know how the crescendo murmur can be explained. I have been able to sort out the most important concept here. So if you definitely see murmur in any question, use the algorithm I have developed, which is ask yourself, what is the location of the murmur? When you ask yourself the location of the murmur, ask yourself again, what are the maneuvers this murmur responds to? And finally, ask yourself, how does this murmur sound? You will be able to pick out the right diagnosis playing around these three things I have highlighted. Now, moving on, let us now look at these concepts one after the other. When we talk about the aortic stenosis, first of all, you should know how the aortic stenosis graph is. I drew this graph a lot of times in the last class. This is how your aortic stenosis graph will look like. This is the ventricular pressure rising far higher than the aortic pressure. Once you see this, this is definitely aortic stenosis classically. Now, aortic stenosis, the murmur is crescendo decrescendo, meaning the murmur goes up. The murmur goes up and peak and starts falling. So at this peak here, this is the peak of the murmur. This is where you hear the murmur loudest. This is where you hear the murmur loudest because this is where it is peaking. Now, we quickly move on. Now, when we move on, if a patient, what are the causes? What are the likely causes of aortic stenosis? Aortic stenosis is caused by narrowing of the aorta because you don't have, what I mean by narrowing is narrowing of that space. The valves become calcified, it becomes thickened, that it becomes difficult to move it aside. So if you cannot move it aside, that opening space becomes narrow because you cannot dilate or you cannot expand the valve in such a way that you get a complete patency. Now, there are two causes of aortic stenosis depending on the age you see it. If I see aortic stenosis in an older patient, especially those ones above the age of 60, it is caused by calcification of that valve. But if I'm seeing aortic stenosis in a younger patient, maybe 40, or thereabout, it is caused by Biskowski aortic valve. You can see Biskowski aortic valve in certain conditions, such as Turner syndromes. These people will definitely have aortic stenosis at a very early age. Now, if you look at the symptoms of aortic stenosis, it comes with what we call the SAD. It comes with syncope, angina, and dyspnea on exertion. Now, most people that have aortic stenosis, if they are not exercising, they are good. If they are not exerting, they are good. The reason is this: the valve at this point in time cannot open normally. So let's assume this is the normal person's aorta. Look at how open it is. Blood is coming through in large quantity. This patient is good. Look at somebody that has aortic stenosis. The valve becomes stenosed. The valve can no longer move out. So this is the only space blood has to enter. So you can imagine it is only a reduced amount of blood that can flow through this aorta. Now, that reduced amount of blood will be able to sustain you if you're not doing anything. Because when you're not exerting, you need just a small amount of blood to definitely get you going. So that small amount is enough to sustain you. But the problem is when you decide to not exert yourself, you want to exercise or do any other thing. Of course, your demand goes up, but this valve is already calcified, like you're having stenosis, which cannot move out. So what it simply means is that once you exert, the blood that is entering the aorta is not enough to maintain your metabolic demand. Dyspnea will happen because you're not getting enough. Syncope will happen because there will be reduced blood going to the brain. You will have angina, reduced blood going to the heart. Every system is no longer getting enough. That is what precipitates those symptoms the person has. So that is classically what you see in aortic stenosis. Now, when aortic stenosis disease is getting severe, when it is getting severe, it is usually marked by certain properties. For example, you will hear a soft S2. Now, why will you hear a soft S2? When aortic stenosis is getting severe, the aortic valve becomes so calcified that it even finds it difficult to slam shut. So you discover that the S2 will definitely go soft. Now, the next thing is that you can have what we call the pulsus pavus tardus, which is definitely the weak rising pulse that has a very delayed peak. Now, in a normal person, when you want to eject blood from the ventricle, you will discover that the aortic valve will open rapidly. It will open rapidly and the blood will leave and it will also close, saying everything is normal. But now this aortic valve is calcified. A calcified valve will take time and energy to open. Just imagine, use your door, the door in your house to imagine this. If the door in your house it's normal, it's very free, it is not stiff or rigid. If you want to access the door, all you need to do is just push it. Just use the door handle, open and just push, you're in. But imagine that same door becomes stiff and it definitely has a hook that is holding it and you're trying to get into that room. You will take a lot of time opening that door. You take a lot of time and energy to open that door. That is exactly what happens. In aortic stenosis, the valve is calcified. So it takes a lot of pressure and a lot of time to be able to force this valve open. So you find out that you have a slow rising pulse before it peaks. The more severe it is, the slower it gets. That is what is called the pulsus pavus estadus. Now, when we look at the tricuspid and the mitral regurg, like we said, both of them has holosystolic murmur, but both of them are seen on different sides. Tricuspid is on the right. Tricuspid is on the right. The mitral regurg is on the left. Remember when you hear them, tricuspid, left lower sternal border. Mitral is at the cardiac apex. Now, what are the causes of these murmurs? Let's look at the mitral regurg. What are those things that can cause mitral regurg? If you look at the mitral valve, we didn't do the anatomy, we just started physiology. In this pathway, you just need to know a lot so that you can marry in all the concepts together. Now, if you look at the heart, basically, looking at the heart now, um, you can classically see the valves. Let's use this to be the mitral valve. Now, see what the mitral valve does. The mitral valve helps prevent blood from moving from the ventricle back to the atrium when the ventricle is contracting. And it also helps to hold the blood intact in the atrium when the atrium is relaxing so that it doesn't force those blood prematurely into the ventricle. So it coordinates a lot of things. But this your mitral valve now is being held together by certain muscles that are called the papillary muscle. So let's say this is the papillary muscles. Now this mitral valve is attached to these papillary muscles. You can see this. It is attached to these papillary muscles. This is how it is attached classically. Now, it is these papillary muscles now that is holding them in place. So if a patient has myocardial infarction means that there's a fixation of this particular papillary muscles. If this papillary muscle is affected, this papillary muscle is affected, nothing to anchor this particular mitral valve anymore. The mitral valve will definitely prolapse. It will definitely become incompetent because nothing is holding it in place again. Of course, there will be regurgitation. This is what will happen now. It will definitely collapse. To definitely collapse because of that support that is gone. Regurg happened. So that is why mitral regurgitation is very common in myocardial infarction. Now, it could also be a prolapse and it could also be left ventricular dilatation. That is another sweet one. Now, let's assume this is the normal heart. Let's assume this is the normal heart of a normal person. This is the size. You can see the mitral valve closing everywhere normally. Now, let's assume this same man developed heart failure and he has congestion in the heart and the heart now dilated to this point. Look at this patient. The patient has developed congestive heart failure. The heart has now dilated to this point from what it was originally. It has now dilated because of the increased fluid is accumulated, that is accumulating in it. So we're taking out this. We're taking out this. Now, if you observe, this mitral valve is no longer capable of stretching to the both ends of this dilated heart. If you look at this image now, they did not get to the end of this dilated heart. So this area is free. Blood can regurgitate from this area back into the atrium. Blood can also regurgitate from this area and this area back into the atrium. This is called the secondary type of mitral regurgitation because of the congestion in the heart that has pulled the heart aside, leaving the mitral valve very vulnerable. Now, if I give this patient furosemide, that is IV furosemide, and this patient loses those excessive fluid, once they lose the excessive fluid, the dilatation in this heart will go away. Once that dilatation goes away, the heart will return to the original size. So this one now, once I give furosemide, this dilatation will go away because the excessive fluid is taken out. You can see the heart now coming back to its original size, and you can see that regurgitation disappearing. So in secondary mitral regurgitation that is caused by dilatation, that is caused by left ventricular dilatation, mostly it is not a structural problem. It is more of a functional problem. By the time you definitely take away the cause of that dilatation and it returns to normal, the regurg goes away. Unlike in post-MI regurg that will definitely need repair, or it will definitely continue. Now, when you look at your tricuspid regurg, this is the right side. So anything that does the same thing that happens on the left, on the right, we definitely give you tricuspid regurgitation. So tricuspid and mitral regurgitation just protect the same place, one on the left, one on the right. All the thing that causes mitral regurg, if you reverse it to the right, it will cause tricuspid regurg. Now, when we talk about the mitral valve prolapse, this one have just crescendo murmur. This is the one that have the mid-systolic click. And of course, you hear it at the cardiac apex. Now, what you need to understand is that mitral valve prolapse, when it starts initially, it starts as mitral valve prolapse, and you hear the murmur of mitral valve prolapse. But when it has proceeded for a long time, it can switch to give you murmur of mitral regurgitation. You can see it under the mitral regurgitation. It is one of those causes. Now, you should know that what is causing this is when you have tensing of the cordial tendineae. That is what anchors the mitral valve to the papillary muscle. If there's that tensing of it, you can have the mitral valve prolapsing on itself. Now, ventricular septal defect, where do you hear this murmur? You hear this murmur at the tricuspid area, which is the left lower sternal border, which is at the fourth intercostal space to the left of the sternum. Now, see something I want you to understand. You have to be smart. You have to be smart. Look at the tricuspid regurgitation. Look at the ventricular septal defect. Two of them are seen in the same location, the left lower sternal border, and two of them sound the same way. They are holosystolic murmur. But you have to be smart now. You don't have to be a robot. You have to understand that VSD is a congenital problem. You will see VSD likely in children. Tricuspid regurgitation is not common in children. All these disease processes are something that occur later in life. So if I'm hearing a holosystolic murmur at the left lower sternal border in an adult, I'm thinking of a tricuspid regurg. But if I'm hearing that same murmur in a child, I'm thinking of a VSD. Basically, now larger VSD have more quiet murmur than slower VSD. A lot of people will be thinking, how? If the VSD is large, we're supposed to get more murmur. Why are we getting less murmur from a large VSD? Now, the truth of the matter is this. What causes this murmur is more of turbulence. That is what causes the murmur, turbulent flow. So come to think about it. If you have two different holes, if we have two different holes, this is a small hole, and this is a very big hole. And I'm asking you, so let me take this out and draw it completely. So this is a small hole, and this is a big hole. And now I'm asking you to push the same amount of fluid or the same amount of substance through these holes. Let's assume the substance you want to push to force through is this size. You want to force this size through each of these holes. Now, for you to force this size through this blue hole, you will have to make a lot of noise because you have to reduce it to the size of this hole to force it through. Now, for this big one, you will just slide it through and nobody will even know you have slided it. So the smaller the opening, the more turbulent the blood will be when they are trying to pass through it, because the opening is narrow. It creates more friction. That will definitely create more mechanical wave, because they will definitely be sliding through one another and against the wall, unlike when it is large. So if I get a very faint VSD, I should even be worried. I will not say, oh, because it is faint, I think because I'm hearing a faint murmur, oh, and this is a child, oh, this can just be a small VSD. That is when I'll be worried to quickly do an echocardiography. Now, see, there's another trick you would need to have at your disposal. There's just a lot of information in this pathway, but the more information you have, the better for you. Now, when they want to press you on murmur, look at your UWORD, your MBMEs, or any other question banks like AMBOS. If they want to press you on murmur sometimes, they may not even tell you, oh, it's a grade 2 overseas holosystolic murmur. They can go in another dimension and tell you on auscultation, the patient had a systolic murmur, or the patient has a diastolic murmur. They will not give you the location. For example, the patient had a systolic murmur, best heard at the left sternal border, or the patient has a diastolic murmur, best heard at the left sternal border. Now, all your murmurs are systolic murmurs, except for just two. There are two diastolic murmurs. Murmur of mitral stenosis and murmur of aortic regurgitation. Those are the only two diastolic murmur. Others are systolic murmur. Now, look at this. Look at this clinical vignette again and pick out your answer. They told you a 44-year-old woman came to the hospital with dyspnea on exertion, easy fatigability, orthopnea, and they gave you plenty other things. They now told you that on auscultation, the patient has a diastolic murmur best heard at the cardiac apex. Automatically, that is mitral stenosis. There are three murmurs at the cardiac apex: murmurs of mitral valve prolapse, murmurs of mitral regurg, and murmur of mitral stenosis. Of these three murmurs, only mitral stenosis is a diastolic murmur. So that gives you your answer, and you move on. If they mistakenly put a cardiac auscultation finding, which they will put most times, if you look at your U or you look at your AMBOS or MBMs, if they mistakenly put that, it will be an error for you to fail that question. If you did this section with me, it's going to be like an unforgivable event for you to fail that particular question. You shouldn't fail it. Now, let us look at the diastolic murmur, basically. Now, when we talk of the aortic regurg is a decrescendo murmur. You're hearing the murmur and it's fading and fading continuously. It just keeps fading. There's nothing you can do. You just find out that, oh, this keeps going down and it is still going down. That is definitely the regurgitant murmur. Now, the other thing is this. What you need to understand is where you can hear the aortic regurgitation murmur will be dependent on what is causing it. Now, if you remember, I told us that the aortic regurgitation murmur is heard at the left sternal border, alongside with pulmonary regurgitation and murmur of hypertrophic cardiomyopathy. But that is when the problem is due to aortic root dilatation. That is when the problem is due to the aortic valvular disease. What we looked at there was valvular areas. Aortic regurgitation can follow a lot of pathology. It can be that the valve is having a problem, or it can be that the aortic roof is dilated. Now, if it is due to the valvular disease, you will hear it in that location. What we're doing in that auscultation finding page was definitely valvular disease. But if this regurgitation is due to aortic root dilatation, you will hear it at the aortic area. That is where you will hear it. You will hear it at the aortic area, which is definitely the right upper sternal border. Please note what I have said. Where you hear the aortic regurgitation is dependent on what is causing the problem. If it is a problem with that valve, you hear it in our normal location, which is the left sternal border. If it is definitely a problem with root dilatation, you hear it at the base of the heart, which is definitely that aortic area. Now, the causes of aortic regurgitation can be somebody that inherited a bicuspid aortic valve. You see it in Turner syndrome. Infective endocarditis can cause it because you definitely have those vegetations on the aortic valve that can damage it. Aortic root dilatation, when you have expansion of the aortic root and it becomes bigger than the valve. This is what the root dilatation means in simple terms. This is the aortic root, for example. This is the aortic valve covering it, this in red. If this aortic root becomes dilated to this point, this is now the new walls of the aorta. It undergoes dilatation for certain reasons. You will discover classically that this valve will no longer be able to stretch to the both ends of this new aorta root. And of course, you will definitely have this gap. You definitely have this gap. You have this gap. If you have this gap now, of course, you can have regurgitation happening. That is the aortic root dilatation. Now, what I want you to know is aortic regurg comes with increased pulse pressure. If you go back to our previous lecture, we settled that. Now, this increased pulse pressure can cause a lot of things. It can cause a whole lot of things. For example, it causes what we call the banging pulse. If you press the pulse, it's like a pistol shot. The pulse is really, really banging. It's like a pistol shot. That is what they call it, the pistol shot pulse. Now, this pulse can be the pressure of this pulse can be so much because of that increased pulse pressure that the person will be nodding their head unconsciously or involuntarily. That is what we call the head bobbing. They don't even know. You can just observe them and you find out that they are nodding their head in synchrony with that pulse, but they don't even know it is definitely happening. If you leave it over time, it can cause heart failure. Now, when you talk of mitral stenosis, please, for this pathway, if you see a patient with mitral stenosis, it has to be an immigrant. He has to be an immigrant. Those are the people that mainly have mitral stenosis. You rarely see mitral stenosis occurring in non-immigrants. It is very, very rare. Like it is extremely rare. It is extremely rare for you to see that happening. Now, why would you see it in immigrants? The thing is that most times your mitral stenosis is a sequelae of rheumatic fever and rheumatic heart disease. Rheumatic fever is caused by strep infection that is not treated. For those of you who are from Nigeria, you know that people don't go to the hospitals here. Children have fever, they have infection, their parents buy them paracetamol, they solve it. And one way or the other, the body has a way of handling these things. Once your immune system is good, you can have infection. And even if you don't take antibiotics, your body will find a way and struggle and sort it out. But the problem now is the long-term sequelae that will happen. If it's in the US, a child has sore throat, yeah, the child goes to the hospital. They look at it, oh, this is strep pyogenes. Oh, this can definitely cause rheumatic fever or post-streptococcal glomerulonephritis. No, we have to be aggressive. They give penicillin and treat it, and everybody is fine and good. So that is why this is more commoner in immigrants. Now, when you talk about mitral stenosis, think of the mitral valve. This is the problem. This is, let me use colors here. This is your atrium. This is your mitral valve here. These are your mitral valves, both leaflets, because the mitral valve has two leaflets. Now, this is your ventricle. This is your ventricle. Now, look at the challenge. In a normal person, these valves are very free. When the atrium wants to empty its blood into the ventricle, this valve will open. The valve will open, and the atrium will empty its blood very easily. Now, in mitral stenosis, the problem is that these valves become calcified. These valves now are calcified. And the problem is this: when the atrium wants to empty its blood, it will have to force these valves that are calcified open. So for the atrium to do that, it will definitely has to increase its pressure. So the pressure in the atrium will go up. When the pressure in the atrium goes up, it will be able to force this valve open, even though it will not completely open it, but at least it can force it open to a reasonable extent. Blood can now leave the atrium into the ventricle. Now, the atrium will have to dilate because it cannot empty all of its blood. All of its blood cannot be emptied. Some will still have to remain. So left atrial dilatation can happen. And when the left atrium dilates, it can definitely predispose to atrial fibrillation. Now, that increased pressure in the left atrium can be transmitted to the pulmonary system, and the patient can definitely have pulmonary hypertension. That is what you see basically in mitral stenosis. That is the pathophysiology. You see the left atrial pressure going very high than the ventricular pressure during diastole. That is because it needs a lot of pressure to be able to overcome that stenosis. Now, by the time the atrial pressure is capable of overcoming that stenosis, it will usually give you a snap. Just imagine if your door is very, very rigid and you're trying to push it open. By the time you succeed in pushing it open, it will make a noise that will definitely tell you that, oh, finally, you have pushed it open. That is the same thing that happened in mitral stenosis. That is what we call the opening snap. By the time the pressure in that atrium is capable of pushing the valves open, you definitely hear that opening snap. Now, there are some confusing things you will need to know. If you hear that opening snap very early, it simply means that that disease is bad. That disease has gotten to a very chronic stage, or it has gotten to a worse stage. Now, a lot of people will tell me that, Shay, you're trying to get this valve open. You're trying to get this valve open. Why is it that me now opening it early and I'm getting the opening snap early becomes bad? Like, it doesn't make sense. It makes sense if you really get to understand it. Now, what the opening snap means is this. This is just what the opening snap means. At this point in time, I have gotten enough pressure to open up that stenos valve. Now, if the opening snap is occurring early, it simply means the pressure in the left atrium has gotten excessively high. The more chronic the disease, the higher the pressure in the left atrium. So when the pressure in the left atrium has gotten terribly high, at that point in time, you can definitely see it pushing the valve open at any slightest opportunity. So once you see that opening snap very close to your S2, meaning it is definitely happening almost immediately, know that that person's disease has definitely progressed. It is definitely severe at that point. S2 is when you have closure of your aortic and pulmonary valve. After the S2 closes, the next thing is that your mitral valve is supposed to open. That is where you get the opening snap. So if two of them are together, it simply means that S2 just closed and you're having the mitral valve opening, evidence by the opening snap, the disease is severe. But if the S2 is heard and it took a while to hear the opening snap, it means that disease is just starting because the atrium has not had a lot of pressure. So it is still trying to build momentum to be able to force open that valve. Finally, when you talk about your patent ductus arteriosus, this is what we call the machine-like murmur. The machine-like murmur in the sense that you hear this at every point in time, whether in systole or whether in diastole. You just keep hearing it continuously. Of course, this will be seen in congenital rubella. If you've done touches infection, you know what we're talking about. When you come to step 2, we're going to tie in a lot of crazy, or I don't want to call it creepy, but I'll call it a little bit of crazy concept concerning patent ductus arteriosus. I won't tie it at this point. There's a lot of things that will be very confusing. I'll tie it at the level of step 2 cardio. Now, let us look at action potential in your myocardium. Now, when you talk about action potential, these are elementary physiology. I think in Nigeria, and this is done in year 2, first semester. For those of you, depends on the school you went to. Some of us who went to University of Port Harcourt, I think that is done in that's done in first semester year 2, if I could remember clearly. Now, you will still need some of this, your basic information, to still be playing around it. Now, if you look at your normal action potential, this is what happens in nerves and muscle action potential. This is your resting membrane potential. Boom, you have a spike, which is depolarization, where you have opening of sodium channel. It peaks, and boom, you have repolarization when you have opening of potassium channel. The potassium channel closes very slowly. So it's supposed to close here, but it closes very slowly. So you have what we call hyperpolarization, which is going below the resting membrane potential. Then it will gradually come up back to the resting membrane potential, and the whole thing will start again. This is what you get in muscle and the nerve fiber, but that of your cardio system is a little bit different. So let me draw that of the cardio system. I want to leave both of them so that we can compare at the end of the day. If it's in the cardio, this is how you also start. The cardio is the one in blue. You start with the resting membrane potential. So let me start talking about it now. Let's imagine the resting membrane potential is about 80. Now, what it simply means is that the membrane has a more negative charge. If you look at your membrane when action potential is not happening, you will understand why the membrane has a more negative charge. You bring in less sodium and takes out more potassium. For example, you bring in 2 sodium and you take out 3 potassium, meaning you're losing more positive than you're gaining. Think about it. Potassium is positive, sodium is positive. I'm gaining 2 sodium, while at the same time I will lose 3 potassium. For any 2 sodium I gain, I lose 3 potassium. I gain 2 positive, I lose 3 positive. At the end of the day, what it simply means is that I am losing more positive. That is why I will definitely fall into a positive deficit, which is the negative line. If I'm gaining more positive, I'll become more positive, but now I'm losing more positive. That's why I'll definitely go to the negative. Now, that is why the resting membrane potential is at negative 80 volts. Now, this is what happens when action potential in the heart wants to start. It will start by opening of gated sodium channel. Sodium channel will open and sodium will come inside. It is not going outside. So sodium will quickly be running inside at a very high quantity and high speed. Now, when sodium is running inside in very high quantity and in very high speed, it simply means that that cell is gaining more positive ion. Automatically, you will see that the membrane potential will start rising towards the positive. This is now going towards the positive. until it gets to about positive, let's say 20. Let's say this is plus 20. You saw that it moved from minus 80 to about plus 20. Now, the reason for this rapid depolarization is because you definitely have sodium channel that has opened, and sodium is coming to the inside. That raised the positivity from minus 80 down to plus 20. When it gets to plus 20, at this point in time, sodium has done its job. The sodium gate will close. When the sodium gate closes, automatically what will happen is that potassium will start moving from inside of the cell to outside. When potassium start moving from inside to outside, it simply means that this cell now is now losing positive charge. Of course, the membrane potential will start falling back towards the negative. So this is what happened. At this point now, sodium is closed, potassium opens. This membrane potential starts falling. But at this point now, something happened. You can see that the membrane potential has fallen a little bit, but something will happen. At this point in time, calcium channel will quickly open and calcium will start coming inside. Calcium is also a positive charge ion. So if calcium is coming inside and at the same time potassium is going outside, it simply means that everything is balanced. Equal, equal. Equal positive is coming in, equal positive is going out. Everything is balanced. So at this time, you now have what we call the play-two, which you don't have in your neuronal or muscular action potential. The play-two is not there. The play-two is only in the cardiac. And the play-two now is because you have a balance in that electron. Potassium is going out, calcium is coming in to balance it up. Then finally, that calcium channel will close and allow only the potassium to still be open. So the potassium will keep pumping those potassium out. Of course, because potassium is going out now, you're losing positive, the membrane potential will keep dropping, but it's going to drop to the resting membrane potential. So you see that this particular rapid depolarization was by sodium channel coming in quickly. It peaked at this point and it closed, and potassium opened and brought a little repolarization, and calcium quickly opened and balanced that positive charge that was lost. You have your play-two. At this point where calcium is coming in, that is where your contraction takes place. Calcium will eventually close, potassium will continue. That is the action potential here of the cardiac muscle. That is what they were illustrating here. That is just it. That is just it. You can see the phase zero. The phase zero is the depolarization by sodium. Phase one is the small repolarization by potassium. Phase two is the play-two, where calcium comes in and balances it up. Phase three is definitely where potassium continues to bring it down. Phase four is definitely your resting membrane potential. Now look at how it differs from your skeletal muscle. I've told you, they don't have that play-two in skeletal or neuronal muscle. Skeletal muscle don't need calcium to come from the exterior to definitely cause contraction. We'll settle that in MSK. They have sarcoplasmic reticulum inside that will communicate via the ryanodine receptors and dump calcium, and contraction will happen. You don't need calcium from the exterior. That's why your calcium channel blockers have no effect on skeletal muscle. That's an entire concept of its own, but that is in MSK. We'll sort it out. Now, another thing is this. This is a little tricky concept. This is a little tricky concept. Now, when you look at your cardiac myocyte, there's a way your cardiac myocytes are. Your cardiac myocytes are connected one to another. You need to do your USMLE in such a way that you should have information so that when you go to a program, you could be able to talk and people would listen. I say there's this ideology that runs around. People just want to pass, make it just be saying, make I just fit pass, fit move on. Yes, in as much as you're passing, you should still be able to get a good grip and understanding of your concept so that when you get to a program tomorrow and you're talking, even though you have AMGs in the program, they will definitely want to listen because they know you have an understanding of your concept. You did not cram those concepts. Because when you start doing the residency, you will start applying the things you know. At that point in time, is at the level of application. If the understanding is in depth, it becomes way easier. Now, look at this tricky concept. This is how the cardiac myocytes are connected. Let me assume this is the right part of the heart. This is the left part of the heart. These cells are completely on different side of the heart. Let's assume that the left side of the heart did not get any impulse. An impulse got to the right side of the heart. These right heart cells will definitely send this electrical impulse via this junction to the left, and the left will also contract. So electrical activity can seep from one cardiac cell to the other via the gaps between them. Where this is important is if somebody is having a left bundle branch block, activity cannot pass through the left bundles anymore, but the left side of the heart will still contract. What will happen is that the activities will go to the right. The right will contract first and send that same impulse to the left, and the left will also contract, even though it is not getting an impulse directly. That is the essence of that connection. Now, there are certain type of cells in the heart we call the pacemaker cells. Your SA node, your AV node, those are definitely pacemakers. And they have a different type of action potential that differs from what you have in the normal cardiac myocyte. We call that one the pacemaker potential. That one has phase 0, phase 3, and phase 4. It is not the normal type of cardiac action potential, This one is seen mainly in the pacemaker cells. And I have called what the pacemaker cells are to you. I have called what the pacemaker cells are. Now, if you look at phase zero is that depolarization phase that moves it from the negative side towards the positive side. But funny enough, this is not caused by sodium channel. These people don't have fast-gated sodium channel. So that is not what is causing this movement. This movement is rather caused by opening of calcium channel. That is what is mediating that phase 0. It is calcium channel mediating it. Now, your phase 3, of course, will definitely be mediated normally by your potassium leaving. Anything repolarization is mainly potassium. Now, when we look at phase 4, when we talk about phase 4, that is where we now talk about the phonic current. That's where we talk about the phonic current. Now, the phonic current is definitely made up of a mixture of sodium and potassium. Sodium is flowing in, potassium is flowing out, but the sodium inflow outweighs the potassium outflow. That is why it is moving towards positivity. Once it hit a threshold of 40, automatically the phase 0 will definitely start. Now, at this phonic current is where you either suppress or increase pacemaker potential. For example, if I want to increase the heart rate, catecholamines can increase the heart rate. It is at the level of this phonic current, they are definitely going to do that. They will just increase the rate at which the phonic current is firing. Automatically, the heart rate goes up. If you want to reduce it, the like of your acetylcholine, adenosines, and others is still at the level of the phonic currents. That is the phase 4. They will act and reduce the heart electric activities. Now, when they talk about ECG, there are just a lot of things associated with ECG you have to know. But before we talk about that ECG, we're definitely going to look at how electric impulses move in the heart. That is what we're going to talk about. How does electric impulses move in the heart? Now, this is going to be super, super important for you to know. If you look at it, electricity, let's use electricity for example. If you get to your house now and you turn on your, you switch on your TV, that TV you switched on is receiving electricity from the socket, which is also getting the electricity from somewhere else. I will have to use, if I use, I would have used an example, but people that are in America that have never been to third world country may not understand. But I think I will still have to use that example because I know quite a lot of people will relate. Now, if you look at your generator, that is what we use in Nigeria basically to provide electricity. If you look at the generator, let's say you have your generator. If you switch on your generator, that is the source of electrical impulse that will power your entire house. The generator will transmit that electrical energy down to your sockets or your junction boxes. From there, it will now distribute it to different rooms because you definitely wired each of your room from that junction box. So every room that is wired to that junction box will definitely pick electricity from it. Then once you've wired it to your room, it's also wired to your socket. Then you connect your TV to the socket, and from the socket, it gets to the TV. So that is the same way in the heart. The electrical impulses originate from somewhere, and it has a particular flow pattern which you have to know. Now, look at the two things you have to know. The flow pattern is the first. So electrical impulses in a normal heart will originate from the SA node. From the SA node, it will move to the atria. A lot of people will think it will go to the AV node. It will fail it to the SA node. Look at where the SA node is. Maybe when you know the location, it should make sense why it should go to the atria. This is the atrium. The black is the ventricle. This is the atrial septum, interatrial septum. Now, this is the point where you have, this is your superior vena cava entering the right atrium. This is your inferior vena cava. This is where, this place here in green is where your SA node is located, just beneath that opening of the superior vena cava. Now, this is where your AV node is located, at this interatrial septum here, this point here. Now, if electrical impulse is supposed to move from the AV node, from the SA node rather to the AV node, it simply means that these electrical impulses will have to go to the atrium first, because this SA node is far from this AV node, but the atria is in direct connection with it because it is sitting in the atrium. So automatically, it can definitely give these impulses to the atrium. The atrium in turn will carry these impulses and hit it to the AV node. So the next thing is this goes from the atria to the AV node. Now, from the AV node, it can go to the bundle of His. So from the AV node, it will go to the His bundle. It will go to the bundle of His. Now, from the bundle of His, it can now go to your bundle branches. That is either the left or right bundle branch. So I'll call this the bundle branches. Now, from your bundle branches, It can now go to your Purkinje fibers. From here, it can now hit the ventricle, which is the last place it goes to. Now you can see how that impulse originated from the SA node and it got to the ventricle by moving through the atria, the AB node, the bundle of His, the bundle branches, the Purkinje fibers, and it strike the ventricle. This is the normal flow of electrical activity. But now look at what is very confusing. Look at what is very, very, very confusing. Now, what is confusing is this. When they now ask you, what is the speed of electrical activity through the heart? This is where a lot of people have issues. This is where a lot of people have issues. A lot of people think that the conduction through the SA node is faster. They think it's the same thing. This is the conduction pathway, but the speed pathway is different. The conduction is fastest in the Purkinje His bundle. So this is the His Purkinje bundle. This is where the conduction is fastest. It happens at a very fast rate here. So the speed of the conduction is highest in the His Purkinje fiber. Now, after the His Purkinje fiber, the next place that has a very high speed is the atria. Now, the atrias, the speed is very high. The next one is definitely your ventricles. And then the least of them or the slowest is your AV node. Now you can see the AV node is like the third sequence that receives electrical impulse in this pathway. But in terms of the speed, the AV node is the slowest. That is what they were trying to put in here. The His bundle to the atrium, to the ventricles, to the AV node. The AV node is the slowest. So don't confuse the pathway or flow of electrical impulses to that of the speed. Two of them are very much different. Now, let's look at the ECG itself. Look at the ECG. Just understand the basics now. It's physiology we're doing. When we enter pathology, we'll start tying it in. Then for step 2, we'll start giving you the ECG to interpret. At that point in time, nobody's baby feeding you again because you're grown up. You should have a lot of information already because after step 2, you're getting into residency. So they expect you to be good. Now, when you look at this is T wave. This is your normal ECG. Now, you know how to draw the ECG. This is the P wave. This is the QRS complex. This is definitely your ST interval. This is your T wave. This is your QT interval. Now we're going to look at what all of these things means. When you see the P wave means atrial contraction. That time you have your atrial kick. That is what is definitely causing the P wave. That's why in atrial fibrillation, you don't get that P wave. The P wave it's absent in AFib. Remember, in atrial fibrillation, you cannot get the A wave. When you look at that hour tracing, the A wave is caused by the atrial kick. So this P wave here tells you atrial contraction. Now, after the atria has contracted or atria has depolarized, the ventricle will follow. But you will need a small interval for that impulse to move from the atria to the ventricle. That is where the PRO segment comes in. The PRO segment now is what definitely slows down that impulse. So it gives some time for that impulse to move from the atrium to the ventricles. Now, the QRS complex simply means ventricular contraction, which can still be termed as ventricular depolarization. So at this QRS complex, the ventricle is contracting. After the ventricle is done contracting, of course, there will definitely be this isoelectric segment, which is the ST segment. That is the time between ventricular contraction and relaxation. The T wave simply means ventricular relaxation or repolarization. They are the same thing. When you talk about your QT interval, it looks at the entire electrical activities in the ventricle, both the depolarization and the repolarization, everything together. Then finally, the U wave is seen in certain abnormalities. When we get to pathology, we'll tie in those things. So this is just the basic understanding you need to have, so that when we start talking about them in pathology, you will definitely be able to follow. At least when I say the QRS complex is prolonged, you should understand that ventricular depolarization is prolonged. When I definitely say there is inversion of the T wave, you should be asking yourself, what does the T wave do? That is ventricular repolarization. If I say, oh, in AFib, there's absence of the P wave, you should know, in AFib, P wave is not there. P wave is definitely the atria depolarization, which is atrial contraction. Yeah, that should make sense. There's no atrial kick. So you will start tying these concepts together and it will start making sense. Then finally, okay, no, that's where we're definitely going to start. So at this point, I will definitely get your questions. I will definitely get your questions. Your questions can come in at this point. Then we can try our hands on a few questions. I want us to get the concepts that has been painted today. So I will definitely